This is my third attempt here to record this lecture. I'm really starting to feel some sympathy for those that are working from home. My girls have interrupted this talk on 2 different occasions, and so I hope that I don't have to record this again. Hello, my name is David Valent, and I'm an ophthalmologist working at Peace Health Eye Care in Vancouver, Washington. I did my residency training at Grandview Hospital in Dayton, Ohio, and my fellowship training at the National Eye Institute in Bethesda, Maryland, under the guidance of Dr. Chu, Dr. Neusenblatt, and Dr. Shen. Today I'll be talking to you about some common uveitis questions and try to answer them the best that I can. Obviously, I can't answer every single question in uveitis, but we will be walking through a common uveitis case that we all deal with on a regular basis and try to answer questions associated or related to this case. I have absolutely no financial interest to disclose other than my student loans. These are my sources. If you have any questions in regards to any of these sources, please do not hesitate to contact me and I'd be happy to provide them for you. Some objectives I hope to provide for you include an overview of frequently asked questions in uveitis. The focus of this talk will center around postoperative rebound inflammation, how to evaluate and treat these patients, and also when to consider a referral to a uveitis or a retina specialist. We will also briefly mention some alternative treatments for uveitis, but we will not be going into any type of procedure techniques or any clinical data, I should say any significant clinical data in regards to these therapies. Before we begin my lecture today, I'd just like to share with you something that has been on my mind greatly over this last month. In December 2020, we had an event on our campus in which an individual shot a temperature checker and then turned the gun on themselves. This occurred literally right outside our back door or our back entrance to our clinic. One of my partners and I were first responders to the scene and provided CPR to both of the victims. The reason why I bring this up is twofold. The first is to make sure to give your family and your loved ones a big hug and tell them how you feel about them. The second would be, as providers, we really need to be prepared for literally anything. And I just would like to make sure that all of you consider getting CPR certification or recertification for both yourself and your staff. I think that that was essential in trying to help these 2 victims. Now on to the lecture for today. Here we have a 56-year-old African-American female who is coming to see you 8 weeks following her cataract surgery with redness, photophobia, and decrease in vision. She had a small flare-up of inflammation once previously as you were tapering her off of her Pred Forte, which you managed topically with increasing her Pred Forte to 4 to 5 times a day, and she completed her taper about a week and a half or 2 weeks ago. On her examination, her vision has dropped from 20/20 when she was last seen to 20/40 today. As you can see from the slide above, she has 1 to 2 plus cell and 1 to 2 plus flare. Her lens appears to be in good position. What should be our next steps for this patient? I never think it's a bad idea, whether it be this patient or any uveitic patient that comes into your office, to take a good review of systems. Some target areas that I always ask about include skin. In particular, I ask about a history of cold sores. But in addition to that, just looking at the patient's skin in general, when you shake their hand or look at their elbows, you can see things like plaques for psoriatic arthritis. I always do a gastrointestinal history, asking about blood in the stool or any history of inflammatory bowel disease. I do a genitourinary review of systems, asking about any genital ulcers. I do a musculoskeletal review of systems. This one gets a little bit gray just because it's hard to distinguish what could be inflammatory joint disease versus just osteoarthritis. I do a respiratory history as well, rheumatologic and autoimmune history, not asking not only just about the patient, but also their family history of any autoimmune diseases. And although with COVID, this next question almost always comes back negative, but I always think it's a good idea to ask about a travel history. The next thing I ask about is compliance with their current therapy. This is something that I always bring up with my uveitis patients, especially when they're not responding the way that I think that they should. Then I pose the question very similarly to those that are on glaucoma drops. I ask, how many times a week would you say that you're missing your steroid drop? There have been a number of patients where with better compliance, we're able to get their inflammation cleared and under control. Really, the next avenue to evaluate would be the eye itself. And I would focus first on the position of the lens, making sure that there's no evidence of tilt, where this could potentially be causing some chafing on the posterior aspect of the iris. I would evaluate the eye for any evidence of previous inflammation. One area that you can evaluate in a little bit more detail is the iris. Looking for iris nodules or any iris transillumination defects to try to help you point you in the direction of, could this be a viral cause? Could this be the lens itself? Could there be little nodules that you would think of for sarcoid? And not even a bad idea would also consider doing a gonioscopy to make sure that there's no nodules in the angle. Lastly, I always make sure to dilate these patients to make sure there's no evidence of any indolent infection. This also provides you an opportunity to evaluate the posterior pole, making sure that there's no evidence of vitreous or posterior segment inflammation or any evidence of macular edema. Now, most people really don't care about this, but I was talking to a pathologist just the other day, and I found out that P. acnes has actually been reclassified due to genetic testing to C. acnes. For our talk, we're just going to continue to call it P. acnes. I just thought that that was really interesting, and if anyone is going on Jeopardy anytime soon, you're welcome. So what are some common risk factors for persistent inflammation following surgery? In the studies referenced in this talk, being a diabetic, African American racial background, and the use of a pupil expansion device during surgery were all associated with a statistically significant increased risk of inflammation following surgery. In terms of why a diabetic would be a risk factor for persistent postoperative inflammation, there have been other studies to suggest that diabetic, or just being a diabetic in general, is a pro-inflammatory condition, and that pro-inflammatory drive could lead to the breakdown of the blood aqueous barrier. For being an African American race, as a risk factor, both articles suggested that this group specifically was pro-inflammatory and was just more likely to have a more robust inflammatory response following cataract surgery. The thought of a pupil expansion device during surgery would make sense in that this could lead to a mechanical disruption of the blood aqueous barrier. The reason why I bring this up is just to keep you and your patients well informed that they could be at higher risk for inflammation, and to consider tailoring their preoperative or their postoperative treatment accordingly. Now back to our patient. After doing a review of systems, our patient had a history of cold sores. There was a family history of some autoimmune disease, but they weren't able to recall what the name was. They stated it was not sarcoidosis from what they were aware of, and the review of system was otherwise negative. The examination of her posterior pole, as shown here, shows no evidence of posterior segment inflammation or postoperative CME. One of the most common questions that I get in uveitis is, when do I get a workup? This doesn't apply just to this case, but almost all of uveitis. So if there is any evidence of bilateral inflammation, and this includes a history of inflammation in the fellow eye, I would always get a workup. If there's evidence of granulomatous disease, such as the patient seen here, if they have a unilateral process, but there's a significant positive answer on your review of systems, I would definitely do at least a focused blood workup there. If there's evidence of scleritis, intermediate uveitis, or posterior disease, those patients I will always get a workup on. Now, for postoperative inflammation, if there were any positive answers to their review of systems, if their eye findings were suggestive of an underlying systemic condition, or if they were just not responding to the drops that I would expect them to, I would consider getting a workup on for sure. I don't usually get them on my post-op inflammation patients unless there's an underlying reason. What should I include in my workup? So I've listed here the most common lab tests that I get for patients with anterior uveitis. I almost always get a CBC, an HLA-B27, a PPD, but I almost exclusively use QuantiFERON Gold TB to evaluate for tuberculosis. Syphilis, both an RPR and a TPPA. Now, I was doing FTA ABS, but I spoke to our local infectious disease doctor, and he had actually recommended doing TPPA over FTA ABS just because it has a little bit better sensitivity. I always get angiotensin converting enzyme and a lysozyme as well. I included here a chest x-ray or a CT of the chest. I don't always get those for my patients with anterior uveitis, but I would strongly consider those for patients with sarcoidosis. This is our form that I created for our office for uveitis workup. Primarily, I did this just so that I didn't forget anything, either when I wanted to do testing, but I can't tell you how many times I've looked at this sheet after looking at the patient and discussing with them and thought of additional questions to ask them just by looking at this sheet. I think it's very helpful as a way to provide a broad and proper differential diagnosis. The one test on this list under anterior uveitis that some providers may not be aware of is a Beta2 Microglobulin. And just to review, that's primarily used for to evaluate for tubulointerstitial nephritis and uveitis. So I almost exclusively get that on my young female patients with chronic anterior or anterior intermediate uveitis in order to evaluate for that further. What if our patient develops macular edema associated with their postoperative inflammation? Does that change my workup or my treatment in any way, shape, or form? And I bring this up primarily because I get this question quite frequently. If my patient develops macular edema, whether it be with postoperative inflammation or just inflammation in general, does that make me more or less likely to obtain a workup? And the answer to this is no. I do not base my workup based off of someone's macular edema. If there's something else in terms of my exam or my review of systems that makes me concerned, then I will definitely obtain a workup. But that could be with or without the macular edema. That is not the trigger for me to do a workup. Now, if our patient develops macular edema, that absolutely changes my treatment management. I'd be much more likely to consider a periocular treatment, such as a Subtenon's Kenalog, as my treatment approach, as there'd just be better posterior penetration with the steroid than a topical agent. Now, the one thing that I have not discussed up to this point is the use of topical NSAID. I never think an NSAID is a terrible idea. I don't think that it's going to completely eliminate your inflammation, but I think it plays a much bigger role if they are used in patients with macular edema for certain. I think that plays a big role for these patients. Would I ever start oral steroids on this type of patient that has resistant postoperative inflammation? I have to tell you, this would be highly unlikely. If this process is monocular, I try to treat my uveitis as best I can with either topical or local therapies. And I would really need to fail multiple therapies before I would consider oral steroids. If the patient had recurrence of their inflammation in both eyes, or I was unable to control them with local therapy, I would start by doing a good review of systems and making sure that I wasn't missing anything, so I would repeat a dilated exam. But this would be far from my initial treatment choice. Interesting, one of the articles that I cited today in regards to postoperative inflammation and risk factors associated with that, 3 of the patients actually did require oral steroids to control their inflammation. So I guess if all else fails, oral steroids may be necessary. I just have never had to go that far in terms of my treatment paradigm. What patient characteristics do I need to be mindful of when starting oral steroids? The first thing that I always look at is the patient's medication list. I can't tell you how many times I've asked someone if they've had diabetes, or they're filling out their sheet when they come to the office and they don't check diabetes, but when I look at their medication list, they have metformin, or they have insulin. I've even had somebody had insulin who denied diabetes. They always tell me that it's been treated. I don't have diabetes anymore. We need to be mindful of these patients, as steroids can really cause some significant changes to their blood sugars. And anytime that I'm starting steroids on a patient and they're a diabetic, I'll always call their primary care provider. I also want to make sure, if I'm starting oral steroids on a patient, that we've ruled out any type of infectious causes, as steroids would probably make those patients worse in terms of their disease. So making sure that you have documented a negative RPR with or without a TPPA is essential. I never think it's a bad idea to have a negative quantiferon gold TB as well, because as we talked about, the last thing you want to do is make them get worse. And for our patients specifically, making sure that there's no evidence of any infectious cause that could be causing their inflammation would be essential.
What are some other treatment options that are available for our chronic postoperative macular edema patients, or our postoperative uveitis patients, or just uveitis just in general? I am not going to discuss immunomodulatory therapies such as Cellcept or methotrexate, as that is in a lecture in and of itself. I will be purely focusing on local therapies today. The one that is most commonly utilized are intravitreal injections. One big caveat: please, please, please be sure to rule out any infectious causes before doing any of these treatments. One intravitreal injection option that is commonly used in uveitis is Ozurdex. This is a sustained release dexamethasone implant that slowly dissolves over 3 to 6 months. Another option would be an intravitreal injection of preservative-free Triesence. Both of these medicines do an excellent job in decreasing inflammation and macular edema, but caution needs to be considered, as both of these are associated with an increased risk of elevated intraocular pressure. Now, in some patients with chronic macular edema, whether it be postoperative or associated with uveitis itself, some uveitis specialists advocate for the use of an anti-VEGF agent such as Avastin, Lucentis, or Eylea. The thought is that there is some mild anti-inflammatory response or effect with these anti-VEGF agents, which could help decrease that macular edema. I was also asked to address a newer steroid treatment called Dextenza. This is a dexamethasone intracanalicular insert, as you can see in the photo here on the right. This is indicated for the treatment of intraocular inflammation and pain following ophthalmic surgery. I have no personal experience with this, and I've talked to several other uveitis specialists, and I'm I am not aware of any that use this for treatment for their uveitic patients or for their chronic postoperative inflammation. Now, in their package insert and reviewing the clinical data on Dextenza, there was a small percentage of patients that developed intraocular pressure elevation, but 10% of patients studied developed iritis or iridocyclitis, which to me suggests that the intraocular penetration may not be high enough, especially for those patients with rebound inflammation or significant macular edema. If anyone who's listening to this lecture has used Dextenza, I would love to hear your thoughts and your clinical outcomes.
How should I manage this patient, or really any patient with uveitis? Now, for this patient specifically, I would probably start with just topical agents. You know that she was quiet previously just with topical treatment, and I would probably start there. I would be okay tapering much slower than what was previously trialed, and even tapering over a month, monthly periods where you're doing, twice a day for a month, once a day for a month, and even consider doing every other day therapy for a month would be just fine and reasonable in order to get their inflammation under control. If I'm unable to control them with Predforte, I would then escalate to Durezol. And for the vast majority of my postoperative inflammation patients, I'm able to get them under control with Durezol. Now, Durezol does have an increased risk of elevated intraocular pressure, so I try to be as mindful of this as I can, particularly with patients that have a history of steroid response. And in addition, I don't hesitate to transition them from, Durezol once a day to Predforte either once or twice a day in order to provide a much more smoother or gradual taper off of their steroid. Because I have seen patients develop a reflare of their inflammation, stepping off from Durezol once a day to just stopping their therapy. So I never think it's a bad idea to do a more gradual or slow approach. If I was unable to control with topical agents, or our patient developed macular edema, as we spoke of earlier, I would consider periocular treatments, with my approach being a subtenon's catalog. Having said this, each and every time where I am going from topical treatment to periocular or periocular to intraocular, I always try to reassess and try to make sure that I'm not missing anything. So I tend to repeat dilated exams. I'll review or repeat my review of systems with the patient. I'll also make sure that I got all the less necessary lab testing that I want for my patient to make sure, again, that I'm not missing anything. If they're not responding the way that I think that they should, or something else just doesn't feel right, I always would consider making sure that a fluorescein angiogram is considered to make sure that there's no underlying vasculitis or inflammation that I just may not be appreciating in terms of my exam. But just this route, I think, of going topical, periocular, and then intraocular, particularly if someone has monocular inflammation, is a totally reasonable approach. Now, let's say this patient has bilateral disease and this is more of a systemic cause, then using immunomodulatory therapy rather than an intraocular route would be probably indicated, or going to steroids at that point would be totally rational and indicated. This is another question I get quite frequently. When should I refer? Honestly, anytime that you don't feel comfortable managing the patient, consider a referral to a uveitis or a retina specialist. There are still times where I refer patients that I don't feel comfortable managing, and that's okay. I sometimes struggle with this because you always want to keep those patients as long as you can, but it may be in the patient's best interest to refer in order to make sure that they're getting the best care possible. Also, if you've tried other therapies and they're just not responding appropriately, or you're unable to control their inflammation, those are never a bad idea to consider a referral. Also, the one thing that I did not put up on this slide is if there's any thought of infection, please refer, whether that be to a uveitis or a retina specialist. A referral is totally indicated at that time. Now, if you live in a more rural community or one that does not have easy access to a uveitis specialist, calling one on the phone or emailing one, that includes myself or, the other uveitis specialists that are presenting today. Most of us are extremely nice. We completely understand how difficult treating some of these patients' intraocular inflammation can be to treat, and we'd be happy to help where we can. So please do not hesitate to refer or to contact us. One question that I've had a big increase in over the last 3 months, not only from patients but from other providers, is whether or not my patient with uveitis should get the COVID-19 vaccine. And the answer to that is absolutely yes. There's been absolutely no data up to this point suggesting that the vaccine causes any increase in inflammation or causes any recurrence of inflammation of the eye. Now, having said this is purely anecdotal. I just had a patient who had the COVID vaccine last Friday and had a flare-up of his scleritis on Monday. Now, obviously, it's impossible to know whether or not these two are completely correlated, but I would still recommend them getting the vaccine, as having COVID is much worse than having a recurrence of their inflammation. I really don't think there's any question there. The potential for the vaccine to cause a pro-inflammatory response, is possible, but I think that the positives greatly outweigh those small risks, and the recurrence of inflammation can be treated.
Another question that I hear quite commonly is, what if our patient develops a posterior capsular opacification, particularly in our patient who's had recurrent episodes of inflammation following cataract surgery? I would want to make sure to have the eye quiet for at least 3 months prior to performing a YAG capsulotomy, just to make sure that you don't induce any rebound inflammation with that treatment. Now, one of the articles that I was reading recently, a provider noticed a PCO developed soon after cataract surgery, and they were having some issues in terms of controlling their inflammation even with drops. And it turned out this patient had an indolent infection, and the opacity that the provider was seeing was actually P. acnes.
Thank you very much for your time today. I hope that I've answered some of the more common uveitis questions in uveitis, with in particular focus on postoperative inflammation. And I hope you've enjoyed this lecture much more than my older daughter enjoyed me dressing up as Santa this year. I hope that you're all safe, and I hope to see you all again in person soon. Thank you.